Hey, it's Dr. Suchard again. Time now for a discussion of miscellaneous antihypertensive drug toxicity. We'll be hitting the high points of Goldfrank's chapter 61. As a general rule, drug toxicity is often an exaggeration of their therapeutic effects. The grab bag chapter here covers a range of antihypertensive drugs, so it's no surprise and nothing to spend any time on if they cause hypotension in overdose situations. The learning objectives here are to cover those notable toxicities and side effects that are not hypotension, and I'm going to be limiting the discussion to clonidine, nitroprusside, and the angiotensin-converting enzyme inhibitors. With regard to clonidine toxicity, clonidine is an alpha-2 adrenergic agonist which can show two unusual features in overdose. Although clonidine is an antihypertensive drug, it's not rare to find patients initially hypertensive right after the overdose, and then later becoming hypotensive. My presumption here is that clonidine, having some structural similarity to endogenous catecholamines, loses its receptor specificity in overdose, resulting in alpha-1 adrenergic agonism. In addition, clonidine overdose can mimic the opioid toxidrome pretty well, where patients can present with CNS depression, small pupils, and even respiratory depression. If you didn't know what the patient had overdosed on, you'd suspect opioid toxicity and might administer naloxone. The literature is mixed on whether naloxone has any reliable effect in reversing clonidine toxicity, but it's definitely not unreasonable to try it. Nitroprusside is a direct vasodilator that may be given by IV drip in an ICU setting for patients with extremely difficult to control hypertensive crises. Looking at the structure of nitroprusside here, we see a central iron atom complexed with an N triple bond O, which is readily and rapidly released as nitric oxide. But there are also 5 cyanide radicals complexed with the iron. The cyanide gets released slowly, and typically slowly enough that the body is able to detoxify it to thiocyanate and to eliminate it. Patients at higher risk of iatrogenic toxicity here are those with underlying renal insufficiency, since they won't clear the thiocyanate or cyanide as efficiently. This is a bit of a sticky situation, since underlying renal insufficiency is associated with hypertension, and hypertensive crisis can cause or worsen renal injury. And unsurprisingly, patients getting higher nitroprusside doses or longer infusions, typically several days, are also at higher risk. Moving on now to angiotensin-converting enzyme inhibitors. In addition to their antihypertensive effect, blocking conversion of angiotensin 1 to angiotensin 2, ACE inhibitors can cause undesired side effects mediated by the accumulation of bradykinin, which is normally broken down by the angiotensin-converting enzyme. The more common of these effects is a nagging dry cough, but it may also cause angioedema. The photo here is a particularly worrisome case of tongue angioedema. Fortunately, this patient appears to be awake, alert, and still breathing through his nose, but this would be a tough airway to control if things got any worse. The treatment options for ACE inhibitor-induced angioedema are varied, and some of them are kind of weird, by which I mean that they involve some rarely used drugs that were intended to treat some other quite rare non-toxicologic diseases. Now, ACE inhibitor-induced angioedema looks a lot like anaphylaxis, and so it's often empirically treated with epinephrine, antihistamines, and steroids. Now, these are pretty unlikely to help because it works through a different mechanism. It's a non-immunologic mechanism. On the other hand, it's unlikely to cause harm. Ecallantide is this large molecule to inhibit kallikrein and therefore reduce the production of bradykinin. And icatibant is a bradykinin 2 receptor antagonist. And based on potential treatments directed toward hereditary angioedema, there is some experience using FFP, fresh frozen plasma, so that we're providing an exogenous source of kinase A, an ACE analog, which will break down the bradykinin. I've seen several patients with ACE inhibitor angioedema, but fortunately none of them were severe enough to need advanced airway procedures or any of these atypical, more or less antidotal therapies. And that's all I'm going to talk about today. There's plenty more to the chapter, but most of that was about supportive care, treating hypotension, and looking for other less esoteric and more predictable exaggerations of therapeutic drug effects. I'll be seeing you around.